Good day, everyone. It's a pleasure to be with you here today, even if via recording, to talk about some of my research on clinician-patient communication processes and outcomes. And even though this is a recording, I will be available for live Q&A after this presentation concludes. So right now, let me share my screen and start the presentation proper. All right, the title of this presentation is Modeling Pathways Through Which Communication and Medical Encounters Can Lead to Improved Health, with subtitles of Pathways, Procedures, and Preparation, which I'll talk about in a minute. Before I get started, though, I'd also like to first thank some of the support that I've received from the National Cancer Institute on several projects, as well as the helpful feedback and comments and influence on my work by my colleagues, Kathy Mazur, Niraj Arora, Ron Epstein, and Rich Kravitz. So today's presentation is going to focus on three things. First, I'm going to discuss pathways connecting communication and clinical encounters to improved health. The second thing that I'm going to do is talk about how we have analyzing procedures for studying and measuring communication behavior and perceptions. Communication can be assessed in any number of ways, and thus it can be complicated sometimes. So I want to discuss and try to unravel that a little bit. And then finally, I'd like to talk about how we prepare clinicians to be better communicators by relying on some of the foundations in communication and linguistic science, certainly some of the work that's been very influential in shaping my own thinking about clinician-patient communication. So these three things can be summarized in this particular graph. So we have the clinician-patient communication that we're interested in, and we are also interested in how that is linked to improved health outcomes. So one challenge we have is modeling the pathways through which communication leads to better health outcomes. In other words, the communication has to activate some processes or sequence of events so that ultimately it will lead to the desired outcome that we want in the care of the patient. So a second challenge are the conceptual and measurement issues with regarding to how we even think about clinician-patient communication. It's very broad. Communication it covers multiple domains. It could be about empathy, information giving, decision making, managing uncertainty. It could be any number of things that can be measured in any number of ways, through observations of what people are doing, through getting people's reports or perceptions of how the communication went. So I'm going to talk a little bit about how we can make decisions about how we think about communication to measure in order to show those linkages to the health outcomes of interest as a second part of the presentation today. And then finally, now that we have some idea about how we think about communication, what do we do with regard to helping clinicians be better communicators by training them, giving them communication skills? So I want to talk about some of the communication foundations that could inform that kind of instruction. So first thing let's talk about are the pathways, and I'll talk about both direct and indirect pathways. Now, let me pose this question first. Does effective communication matter in improving health outcomes? Well, certainly we can say communication is often related to patient satisfaction and adherence. A number of studies show that, particularly if you get patients' perceptions of the quality of that communication. Behavioral measures of communication in there as predictors of satisfaction and adherence, that's a little less consistent, but yet that certainly occurs with some degree of regularity. But how about the relationship of communication as a predictor of better health outcomes? Actually, that doesn't happen very often. And that doesn't mean that communication doesn't matter. What it means is we haven't been thinking about communication necessarily in the right way of how we can think about it so that it could lead to the health outcomes of interest. And that's what we'll talk about here first. So this is a graph, a model that many of you may be familiar with. So we have our clinician-patient communication that we're interested in, whatever element it is. Empathy, information giving, decision making, whatever. And here are some health outcomes we might be interested in: disease management, pain control, psychological well-being, better function and vitality. If we use a communication measure to predict a health outcome, we are in essence assuming there's a direct path from the communication to the health outcome. And that's not how it's going to work most of the time. True, you can have show empathy, use touch, do comforting messages or reassurance. That could alleviate some, psychological distress, at least temporarily, contribute to emotional well-being somewhat. But more often than not, that's not the way it's going to work. You just don't talk and people get better. Rather, it's going to be through a more indirect or circuitous path where the communication accomplishes something immediately. The patient has a better understanding of what's going on. The clinician has an understanding of what's important to the patient. Clinician and patient reach agreement on what's going on and what to do. They have a sense of rapport and trust in one another. Patient feels motivated to follow through on the plan. And if you can accomplish that in the consultation at that time, then that could lead to some intermediate outcomes, such as the patient gets access to the care they need, they stay committed to a treatment program, they develop self-care skills, or they develop in terms of managing everyday activities in a healthier manner, or they're better able to manage distressing feelings and whatnot. So if you can accomplish that, then that might lead to the outcomes of interest. So let me give you an example of a couple of pathways today. The first one is pain control in cancer. So patients who have advanced cancer often have difficulty controlling pain and controlling the side effects of pain medication. And so what we're interested in here is for those patients who have moderate to severe levels of pain, periodic pain with their cancer, the pathway for them to have better control is to change the pain management regimen. It's pretty simple. What they're doing right now isn't working. So what we need to do is get the clinician to make an adjustment. So that's the pathway we're going to talk about, getting the clinician to make a change in treatment. Okay, so in this particular study, the outcome we were interested in was better pain control at 6 weeks following the consultations of the clinician and the patient that they had. The communication behavior we think that will activate and get the clinician to make a change is more active patient participation discussing pain-related concerns. Patients oftentimes don't do that, either because they're not sure they're supposed to, or or they're waiting for the doctor to ask about it, or they just are resigned that pain is just part of cancer, or they're just being stoic about it or something like that. But we figured if they will talk more actively, openly about pain concerns, that can get the clinician's attention to make some adjustments. So that would be the pathway we're interested in. Is there a change in pain medication, either a new medication or a change in dose? And in this particular study, we had 135 patients with advanced cancer who consulted with their clinicians, and these consultations were audio recorded. And the design we had in the study was a randomized controlled trial in which patients were either assigned to the patient activation coaching or general pain education. So the coaching session was when they would, a lay health educator would visit with the patients, and they would talk about how important it is to talk about their concerns, including their pain-related concerns. So they said, it's important for you to talk. The doctor wants to hear about what's bothering you and things like that. So please speak up and bring up your questions and concerns about pain or any other issues. Here are some strategies that you might be able to use. Say, write some things down that you want to ask or that you want to talk about. Take that into the consultation with you. Here, let me practice with you. How would you bring this up? How would you mention this to the doctor that this is something that bothers you? So that was the coaching intervention. The general pain education intervention, the patients were just given some materials about pain management. All right. So as I said, these were audio recording, and we assessed pain at baseline, pre-consultation, and at 6 weeks following the consultation. So here's our intervention. Here's our pathway. The coaching intervention is going to help activate the patient. That more active patient participation is going to lead to change in pain meds. That's going to lead to better pain control at 6 weeks. All right, so our primary research measures were these. The frequency with which patients were engaging in active participation. That is, how often were they about pain? How often were they asking questions, expressing concerns, stating preferences, making requests? The more in which they're doing that, the more it's entering into the conversation and bringing that to the clinician's attention. Change in pain medication was simply the patient self-reporting of whether the clinician made an adjustment by either giving them a new medication or by changing the dose, or if they didn't, or if there was no change at all. And then pain improvement was assessed by a greater than 1 point improvement post-consultation on the patient's baseline score, pain score on the 10-point scale. So here were our key findings. First of all, more active patient communication about pain-related concerns and issue was associated with having received the activation, the coaching intervention, as well as having greater pain at baseline. Having greater pain at baseline, prompting a patient to talk more about pain concerns is not surprising. Those patients might be more motivated to talk to their doctors about this. But the fact that these two variables had independent effects on the patient being a more active participant about pain-related issues. What led to greater likelihood of pain medication adjustments? More active patient participation about pain and having received the coaching intervention. And of the patients who received a change in medication, 49% of those, almost half, reported improvement in pain control, and just about a quarter of those who had no pain management adjustment reported improvements in pain. And that did reach a level of statistical significance. So what that means is our pathway ended up being like this. The coaching intervention and patient's baseline pain led to more active patient participation. Coaching and patient participation led to change in pain meds, which then was associated with pain control at 6 weeks. Now, what's important about this is that the coaching intervention was not related to pain control at 6 weeks, nor did the active patient participation predict pain control at 6 weeks. But both of them did predict the change in pain medications that then predicted pain control. And this is an example of an indirect pathway that communication led to an outcome of interest of better pain control for patients with cancer. All right, so let's look at a second example with a different pathway. So in this study, we had patients who had osteoarthritis of the knee and who were receiving acupuncture. This was the first time any of them have had acupuncture before. And so the outcome we were interested in is less pain and better knee function for these patients that had osteoarthritis of the knee. So what was the pathway? Well, pain and function, they're subjective experiences. You know, for some people can tolerate more pain than others. So we figured, since this was a subjective health outcome, that activating something subjectively in the patient by raising their expectations about the treatment's effectiveness, feeling more positive about the course of treatment, that if they felt better about the treatment that they were receiving, and they felt hopeful and optimistic that it might work, that might have some therapeutic value in affecting subjective experiences of pain and function. So the outcome we were interested in was better pain control and function at 6 weeks post-treatment. The pathway was raised expectations for treatment effectiveness. If I feel hopeful that treatment might work, I may feel better during the course of treatment. And in this case, the course of treatment was over the 5 or 6 week period, in which, following their initial assessment and discussion with the acupuncturist, there would be 10 to 12 acupuncture sessions over that period. These patients were 315 patients with osteoarthritis of the knee. And the outcome we were interested in was patient satisfaction with treatment process 4 weeks into treatment. And the communication intervention we used in this study was whether or not, and the degree to which the acupuncturist communicated high positive expectations that treatment might work without being misleading, or were neutral or non-committal in their expectations for treatment success. So, for example, the acupuncturists that were initially assigned into the high expectation conditions were to use language like this in that initial visit. I've had a lot of success with patients with your kind of knee pain. I'm hopeful and optimistic this could work for you. You're likely to feel better, start feeling better after about 4 or 5 treatments. If it's not working, sometimes it takes a little longer, but usually it will work some. So those were the high expectations. Then other acupuncturists were trained in neutral expectations, non-committal. It works for some patients, but not for others. I'm not sure if it'll work. We'll have to wait and see if it works. It may be working, and it may be that it's not working, and maybe it will after a few more sessions. So the acupuncturists who were initially trained to have communicate higher expectations were then midway through the study, then coached in terms of how they could do neutral expectations. And likewise, the acupuncturists that had neutral expectations in the first part of the study then were trained to have communicate high expectations midway through the study. All right, so here were our research measures. So each audio recording was analyzed by coders who made a judgment about the degree to which the clinician was communicating hopeful, optimistic expectations. And so they did it on a visual analog scale here. For each consultation, there was an expectation score. Patient satisfaction was assessed at 4 weeks, satisfaction with the course of treatment. And then pain and function measures, typical ones that are used for patients with osteoarthritis, were used and assessed 6 weeks following the end of treatment. So here were the results of our study. Indeed, there was the relationship of higher expectations was associated with greater satisfaction with acupuncture 4 weeks in, as were the patient's baseline expectations. In other words, patients came in with some having higher expectations than others at the start of the study. So these two, the communication of expectations and the baseline expectations, were positively associated with and predicted patient satisfaction with acupuncture 4 weeks in. They had independent effects. And then the patient satisfaction with acupuncture then predicted better self-reported function. I didn't include the pain analysis here, but it was essentially the same here, as that satisfaction was associated with both better function and less pain. Again, what's important here is that the expectations did not directly predict functions, nor did the patient's baseline expectations predict better function. They just predicted patient satisfaction, and that in turn predicted the better function. Again, another example of an indirect pathway in which, though communication was not a predictor of the health outcome, it did predict an intermediate variable that was associated with a better health outcome. All right, so let's move to the second part of the presentation today, talking about procedures, in particular methods and measures. And if we think about the current state of clinician-patient communication measurement, what we have are many measures out there, and they're mostly research program specific. I have a set of measures that I oftentimes use. Somebody else has a set of measures that they use. And there are not many measures that are used across different research programs. And rarely do researchers state or justify their assumptions about the nature of communication process and outcomes, and the selection of measures based upon that assumption. In other words, why are we using a certain kind of measure when these measures can be measured in so many different ways and focus on so many different domains of communication? There's very little justification of that in much of the research. So let's look at this in the context of patient-centered communication. All right, most of us know that patient-centered communication, that's usually a good thing. You know, we need to have more patient-centered communication in consultations with patients. But what exactly is patient-centered communication? Well, we can look at it in a couple of ways. If we ask what is patient-centered communication, then basically we're talking about conceptual issues. And I'm not going to talk about that today. That could be a discussion that'll take an additional 20 minutes to focus on that. But since I'm talking about methods and measures, what I thought we would do is talk about how should patient-centered communication be measured. Well, in making that decision, let's think about what patient-centered communication might be. So how do we measure it? Is it an attribute of an individual or the interaction? So is it an individual that is a patient-centered communicator? A clinician is, or a patient is a patient-centered communicator? Or is an attribute of the interaction? Is patient-centered communication something clinician and patients achieve together? Well, depending on what your answer is, will depend on how you measure it. How about the focus? Do we focus on what the communicators are doing, like we did in the cancer pain study, where we looked at what the patients were doing as active communicators? Or do we focus on judgments, how well it was done, and my perceptions of it, like we did in the acupuncture study, where we were looking at patients' perceptions of their satisfaction with treatment based upon their perceptions of the communication. And then who decides? Who decides whether or not it's patient-centered communication? Is it one of the participants in the interaction? Or is it an observer standing back, watching or listening to the interaction that decides whether or not it's patient-centered communication? So those are important choices to make. And to show you the differences here, I've got some examples here of different studies that take different approaches to how they measure patient-centered communication. So these first two studies here by Aga and Johnson, what they looked at were behaviors. So they in some way, they looked at the proportion of the patient of talking or certain kinds of talk relative to the portion of the doctor's talk. And the more that the patient talks, or the more you have these kinds of behaviors, then that represents more patient-centered communication. So it is focused on the interaction. Are these patient-centered communication occurring in the interaction? It's focusing on behaviors, and it's coded by observers listening to these encounters and then marking the behaviors as they fall into different coding categories. Okay, well, let's switch that. Here is a self-report measure by Kathy Mazur with questions like, I felt listened to, I got the information I needed. It is a judgment, and it's filled out by the patient. The patient reports on the extent to which these things happen. But it's at the level of the interaction because it's focused on communication goals and outcomes. It's not like, did the clinician do something? It was like, what happened? I got the information I needed. I felt listened to. This was something created by both the clinician and the patient. So that's at the level of the interaction. And then Reeve et al. Is similar, but different in another way. It focuses specifically on the clinician. So the patient fills out in a judgment, perception, how well the clinician, or to what extent the clinician and the other doctors had open and honest communication with you, and how much do they give you information and resources, things. So again, the focus is on the individual clinician. It's a judgment by the patient. So here are two others. In this particular case, we have the study that I've used, also focused on clinicians, that ask the patients how well the clinician was doing certain things. It is a judgment, but it could be filled out as a patient self-report or as an observer rating. So for example, this is worded from the observer's perspective. The doctor fully discussed with the patient what was causing the patient's problem. So if someone's listening to the recording and then they mark their perceptions of the doctor's communication. If the patient was doing a self-report, it would be the doctor fully discussed with me what was causing my problem. So that could be patient or observer. And in this one, Stewart measure, that is certainly also focuses on the individual clinician, but it could be both a behavior. An observer of the interaction could make an assessment of the degree to which the clinician explored the patient's disease and illness, tried to understand the whole person. Or it could be the patient's judgment about the extent to which the doctor did that. So in this particular case, it could also be whether by a patient or an observer. So the point that I'm trying to make with regard to these different measures is that there's many different ways that we can look at communication, even a particular aspect of communication, like patient-centered communication. And what's important is they're making different assumptions about what the communication is and how it should be assessed. So there have been several studies have shown that let's take a particular interaction and let's apply 2 or 3 different coding schemes to that interaction to determine whether or not it's patient-centered. Whether or not it's patient-centered often depends on which coding scheme you used. So this is not to say there's a right answer. It's just to say that when we're making decisions about what measures to use, we need to think about how is it that we best capture the communication we think is important in a particular pathway that's going to be linked to a health outcome, and how then with that those assumptions, that knowledge, do we assess the communication that's happening there. All right, so to kind of give you an interesting example of what counts as good communication, let me give you this particular scenario of how this depends on your perspective. So we have a doctor and a patient who are discussing a patient's periodic tremors. The patient is worried, they want further testing, and they are requesting an MRI. The doctor says the symptoms don't warrant that yet. There's medication to try first or watchful waiting, and let's see if that works. But the patient says she's really worried and persists in asking for and requesting the MRI. They go back and forth. Finally, the doctor compromises and refers the patient to a neurologist. The patient agrees. So the question is, was that good communication? And it all depends on who you asked. So the doctor may be thinking that patient was not a very good communicator, was demanding, but I think I handled it okay. I tried to be reasonable. I was given the reasons why we don't need to do that yet, but she wouldn't listen or take that suggestion. So these conditions don't warrant an MRI. So referring her to a neurologist is probably a reasonable compromise. What does the patient think? Well, the patient thinks that doctor's not a very good communicator, didn't recognize how worried I was or seemed to care. Good thing I was assertive. I wouldn't take no for an answer. I didn't get an MRI, but at least I get to go see a specialist. So the doctor says, I'm a good communicator, the patient not. And the patient's thinking, I'm a good communicator, and the doctor's not. But there's a third person that could be involved here, and that's the attending who may be watching it or listening to a recording of it, be shaking his or her head. Not very good on the doctor's part. You have to have tough conversations with patients sometimes, not to push them on to someone else. So again, the thing to think about here is when we're making choices of assessing communication, what do we think is the best way of assessing it relative to the pathway of interest? All right, well, now let's talk a little bit about preparation. And that is looking at some communication foundations for communication skills training. And so I'm just using some examples. They're quite dated, old, although I think they certainly have some lasting impact that were very influential in my thinking early on in my career about how to think about clinician-patient communication. So the first example I'd like to talk about is Grice's cooperative principle. Many of you, particularly if you have linguistics or language experts, are familiar with Grice. Basically, the cooperative principle is the assumption that participants in a conversation, they're going to work together, they're going to cooperate and coordinate their speaking turns in an attempt to be honest and informative and relevant in order to facilitate a successful interaction. So in other words, when two people get together to create one conversation, they got to work together and coordinate with one another in order to have a successful encounter. So how do we think about that if we apply that? What would a clinician understand by thinking about that in the context of a clinical encounter? So mutual influence. So what happens in a conversation is, since two people have to work together on one conversation, each interactant has a potential to exert considerable influence over the other. Because if I respond in a certain way, you then have to respond to the way that I responded. And that's the way we have to coordinate. So that means patients, rather than being in, from status point of view or an expertise point of view in a lower power position, and the clinician is at a higher power position, from a communication point of view, they're equal to one another in the sense that both can have a powerful effect on the course of the interaction. So one thing I've used for that is to think about, let's look at what patients are doing as communicators, and let's focus on interventions designed to make patients more active communicators so that they could have better encounters, consultations with regard to what their interests are. And the other thing is that's kind of interesting to note is that because two people, clinician and patient, are in a cooperative activity creating this conversation, they're going to usually respond to one another mostly in a more favorable way because they're trying to work together. So they have responsibilities to cooperate. So they're going to be more favorably oriented toward their partners, where if you're an observer standing back watching what's going on, you have no involvement in the conversation. You're simply evaluating. The observer's perspective is different from the interactant's perspective. And that's why observers almost always have more critical evaluations of people's communication behavior than do the participants themselves. All right, well, let's look at another linguistic notion: speech acts and adjacency pairs. Clinicians ought to learn about speech acts and adjacency pairs. So speech acts, many of you are familiar with this, are utterances that count as social action. They're not just words, they're actions. So if I make a promise that this presentation is going to end within 40 minutes, then I'm in a position to do that, I've done something that raises an expectation for me to follow through on that particular commitment. But then you couple that with adjacency pairs, which some of you may know are the coupling of two utterances by two speakers, so that when the first utterance occurs by one of the speakers, it obligates a certain response from the other interactant. And there's a high expectation that the other interactant will respond in a particular way. This is a powerful conversational norm. So if I give you a compliment, it is expected that you will show appreciation, not be dismissive. That would be untoward. So, if I give you a compliment, you're supposed to say, thank you, I appreciate that, or something like that. So how does that play out for clinical communication? Well, one of the things I've used a lot are the question-answer adjacency pairs. When a person asks a question, like a patient, there's a high expectation that the person who gets the question asked to, the clinician, will come up with something that counts as an answer. And so that's a very powerful behavior patients can use, clinicians as well, but certainly patients. So this is one of the things I've used to show that patients who ask more questions end up getting more information from clinicians than do those who ask fewer questions and are more passive. But it can work the other way as well. When a patient makes a request, there's a lot of pressure on a clinician to grant it, especially if the clinician's in a position to do so. And so this makes clinicians uncomfortable because they're struggling with the patient has made a request, and this in a cooperative interaction, you're inclined to want to grant your partner's request. But in this case, the request is not indicated by the evidence. Thus, I'm uncomfortable because I'm pressured to accommodate you, but not accommodate you. So those things have to be managed a bit more with a bit more subtlety, and use other kinds of conversational moves like the deflection or asking why a patient might make that request to begin with, thereby shifting the onus back onto the patient to come up with something as an answer. All right, then the last thing I'll refer to is action assembly theory by John Green. For those of you that may not be familiar with this argues that communication behavior, in the production of communication behavior, what we're actually doing as communicators in our verbal and nonverbal behavior, is organized through a hierarchy of cognitive structures that range from quite abstract, the interactional, to quite concrete, the sensory motor. So the interactional is the cognitive representation of the interaction. So in this particular case, it would be, what type of encounter do I have here? Oh, it's bad news, or it's acute care, or it's a basic well visit with no complications. It's a pediatric visit. Could be any number of things. Clinicians would have a cognitive representation of here's this kind of interaction, and here are the kinds of things that happen. Here are the kinds of things I usually do. The ideational is how we manage the flow of the interaction itself. So just because it's acute care situation doesn't mean the same two acute care cases are going to be unfolded exactly the same way. No, this is how you respond and adapt to the given flow of the conversation. So for example, some patients might be real passive, and so you may adapt by trying to get them to be more talkative. Other patients might be quite talkative, so you might adapt by just listening, and then at some time maybe needing to ask some probes to get more information about what's going on. The utterance level is the selection of specific verbal and nonverbal acts, namely the words, the syntax, the gestures and things like that I'm doing. That's referred to as the utterance level. And it's just like the things that are the behaviors that are to be executed. And the sensory motor is what executes it. So in my mind, I'm thinking about using words that come to me like in my mind, I'm thinking about using words. That's what's happening here. The sensory motor is the actual articulation of that and the gestures that I'm using to articulate that. All right, well, why is that important, might you think about in terms of clinical education? Well, here are a couple of implications for that. Clinicians need a toolbox of different kinds of responses. So, that's why they learn things like how do you solicit the patient's agenda? How do you explain things in everyday language? How do you engage in shared decision making? Being thoughtful and mindful about being a good listener and things like that. Those all need to be in your toolbox of things that I can rely upon and use when I need to. And so I need to learn those things. And the thing that's important about that is that it takes practice to internalize them. So if you think about what I'm doing in this presentation, I'm doing lots of things. I'm making lots of word choices and things like that. I'm not thinking about much of the actual words I'm using. I'm thinking more about the purpose of what I'm trying to accomplish. And see, that purpose then activates those things at the utterance and the sensory motor level in order to put out what you're hearing from me today. So the more you practice it, the more you internalize it, and the easier it is for it to come forth and be activated in an appropriate way, especially as you're paying attention to the situation and how you may need to adapt to it. So we practice and practice and practice to learn these kinds of different techniques. So that's level one of our education, to internalize these potentially desirable communication practices. And then the other thing that we need to do then is once we've internalized some things, we need opportunities to improvise. Every encounter is different. Some patients need to be talked to one way, whereas you will talk with other patients another way. And so you don't use all the tools in your toolbox at the same time. You need them there, so you've got to get them, practice those to get them internalized, but then you need to be able to handle different situations from the routine to the problematic, to the ones you're familiar with, to the ones that you are not. So in this particular case, what this theory has implications for in terms of training is how we practice, and then how we improvise in different situations, because at the ideational level, where we're managing the flow of the conversation, this is how we make choices and decisions about how we're going to respond given things that are happening over the course of the encounter. So where do we go from here? Well, one thing is I think we need to spend more time identifying the health outcome and then the pathway, the mechanism for improved health. Once we identify that, then we identify the key communication elements that can activate that pathway. And then if an intervention is needed, how do we design an intervention to focus on those communication elements? We need more thoughtful approaches with regard to the procedures part of this presentation to map our measurement of communication to our conceptualization of communication in accordance with the selected pathway we're interested in. And then I think we need to bring communication, linguistics, and cognitive science into the training of clinicians. I think if there's a stronger foundation in being aware of kind of how communication works in both its more conscious and then more automatic, subconscious kinds of ways, clinicians might be better able to use that kind of knowledge about communication to even be better communicators themselves as they're looking at the medical encounter as much about good communication as it is about good science. So here are some references for my presentation today. These slides are available. If you email me, I'll send you a copy of the slides. And I'd like to conclude by saying thank you very much for this, and I am available to answer any of the questions that you might have now that this presentation is over.